also in the burden in terms of morbidity and mortality. And the Eastern Mediterranean region initially appeared to be less affected, and there has been many speculations as to why this may have been the case, whether it is the limited testing in some countries, early introduction of restrictions, the younger age of the population, or just simply the delay in introduction of the virus. But today, 4 months into the pandemic, infection spread in our region appears to be catching up, and many countries are actually experiencing large and growing epidemics. The region but has also many specificities which need to be taken into consideration, including vulnerability factors such as conflict, economic difficulties, and suboptimal healthcare infrastructure and resources, which complicate the response and also exacerbate the public health, social, economic, and economic impact of the epidemic. So to introduce today's topic, mathematical modeling is playing an important role in this pandemic by making predictions and forecasts that aim to inform the response. And one of the main models that have been used first in the US, but now worldwide, is the Institute for Health Metrics and Evaluation, the IHME model. And today, our main speaker, Dr. Ali Maqdad, will be presenting the IHME projections for the Eastern Mediterranean region for different scenarios of easing mandates and restrictions. And I would just like to mention that the projections that Dr. Maqdad will present today has been just produced yesterday, and so they have not been yet disseminated on any platform. So the way this seminar is going to go is that Dr. Maqdad will present for about 20 minutes, following which each one of our distinguished panelists, Dr. Haji and Dr. Abu Raddad, will comment for about 7 minutes on the projections Dr. Maqdad will present, based on their experience studying and responding to the epidemic in the region. And so their insights will help put these projections in their local context. So without further ado, I will introduce Dr. Maqdad. So Dr. Maqdad is Professor of Health Metric Sciences at the IHME and Chief Strategy Officer for Population Health at the University of Washington in Seattle. Prior to IHME, Dr. Maqdad worked at the US Centers for Disease Control and Prevention. He has published groundbreaking research on local level disease trends and leading risk factors for poor health. His work on obesity is among the most highly cited in the field. Dr. Maqdad, the floor is yours.
Thank you. Let me share my slides. Okay, so good morning, everybody, and good afternoon for you. It's a pleasure to talk to you about the COVID-19 projections for our region. So I'll be very brief and looking forward to the discussion. So briefly, I will introduce the model, some limitations, what are our projections for EMR, and how can countries in our region use them, and what are we trying to do as we move forward, looking ahead from IHME and others. I have a lot of slides, so I will leave the presentation with all of you, but I'm not going to cover all the slides, but I wanted to have a comprehensive slide for all of you. We have a wonderful team working on COVID-19, our director, Chris Murray, and several modelers who are worked on this one, and different researchers, and a lot of people who are doing global engagement to get the data from every country in the world. IHME all briefly focuses on the world major health problems, how is society addressing them, and the third and the most important one, which we're doing a lot of work right now, how we can best allocate our resources to maximize health improvement in the world. And one of our main products, as you all know, is the global burden of disease. Our model, we started modeling mortality because early on nobody had enough tests, so we didn't know how many people are infected in a community, instead of using the regular infectious disease modeling for projection, which I'll briefly cover. So our modeling was at the request of University of Washington Medical Center. So basically we did it for our own hospitals to prepare for the surge. And we provided them data on how many beds they need, how many ICUs, and how many ventilators. Early on, we didn't have mobility data. Now we have mobility data, as I will show you. So we used the mandates that every country put in place early on when we started modeling for the US, we didn't have experience in the US, so we used what we have seen in China, Italy, and Spain to inform our models in terms of prior, how death rate will change from one day to another day in our projections. Once we had our own data, we switched to our own data, of course, for every country in the world, we're doing those. And we're providing right now scenarios, once we have a model projection, which is our reference model, we can provide lots of scenarios if we change some of the variables, and I'll briefly mention that. We're doing age-specific and sex-specific modeling whenever we have the data. In the US, we have that data. And we followed mean time from transmission to death. We have hospital admissions, and then we look at the ratio of admission per death. Once we have somebody in a hospital, we have a length of stay in that hospital. So how many bed days that person took, we have the average, how many of them needed ICU, how long they stayed in ICU, how many needed ventilators. And of course, this changes throughout the time as physicians get more familiar with how to treat COVID-19, whether they admit or not. So early on, for example, we overestimated the needs of hospital beds in the United States because for every death we had 11 admissions. 3 weeks into the pandemic in the US, for every death we had 6.6 admissions. So, I mean, this is a moving target. So we allow a random effect in our models to address that. Lots of data sources that we have, mainly coming from Hopkins, because they accumulate all the data. And once we reach out to a country, they provide their own data. Unless it's totally different from Hopkins, we prefer to use Hopkins to allow the comparability across all locations that we provide data. We have the COVID tracking project. Social distancing mandate is from the government. Mobility comes from Facebook. Data for Good, this is a survey that Facebook does. Google SafeGraph and Descartes here in the US. They use mask use globally is from Facebook, and for the US, they don't ask this question as part of the Data for Good. We get it from Premise, another survey agency here in the US. We have 6 measures of social distancing mandates, which is closing of educational institution, non-essential business, people ordered to stay at home, severe travel restriction, like Lebanon shut down the airport, and partial non-essential business order to close, and of course restricting group gathering, and that varies 50 and above or 100 and above. It depends what the government does, and we account for all of these. Why we use mandates? Because if you look at this graph on the right side, for example, in Colombia, and that's true for every location, even before there was any social mandate, mobility went down. Now that we have mobility data, we can follow that. And even before the relaxation of any social distancing mandate, mobility started going on in anticipation when a governor or a state start talking, or a country, about considering easing the restriction, people start getting out. And we have noticed throughout this pandemic that a news will impact the behavior, and you see mobility increasing depending on how the country is performing. It gets worse, and then you see increase in mortality. It gets in the news, then people start staying at home. So we add a variable, assuming that people who stayed at home early on are not going to go out of their home until the last mandate is being relaxed. All what I'm presenting is on our web page, and we will have a new release globally. So the numbers I have will go to end of October, because we've released for 4 months. Today is July 1st, so we're pushing for 4 months, and you will see different numbers if you go to our web right now from what I'll be showing you, because we have new numbers and goes for 4 months with extending 1 month. IHME model briefly takes daily deaths, total deaths, hospital resources, the mobility, the testing, and confirmed and estimated infection, which is very important for us. We don't only report confirmed infections, we report estimated infections in the population and use that in our model. We have 3 models that we have used, and again, very briefly. The first model was a curve fit model, and it did extremely well early on and predicted the peak in the United States, and in every country did very well when we used it for China, Italy, and Spain. It started performing miserably when we started past the peak when the data start coming down. So we moved to a susceptible, exposed, infected, infectious, 2I, and removed recovery or death hybrid model between May 4 and June 10th. And now we're doing a random knot model with the SER model, and we're using several covariate in our modeling. And I will discuss these variables one by one. The way we do our modeling at IHME, we compute the past 8 days and we project 8 days into the future. Why 8 days? In our model, it turns out to be the best cutting point. Weekends, the numbers come down and they start going up again in the early the week. So if you look at the reporting for us coming from every country in the world, no criticism, people are running to provide the data. We see mortality on Tuesday will be the highest, and because they're catching up what happened over the weekend and Monday. And then we use 8 days and project the next 8 days at IHME. The SEIIR model has the covariate in it, but one thing that's totally different in our modeling, and without going into a lot of details in the model, we put a like a safety measure on our modeling by remove. So people get infected and they take some time to be infectious. So we have 2 eyes here. And then we allow in small locations. Otherwise, this is the imperial mistake when they went exponentially in terms of deaths. We move people from those who are infected and infectious to exposed to allow for the model not to go exponential. So basically we say, no, it reaches a certain point, people are going to behave and then going to dial back some of the measures, and we allow this to go back. Why I'm mentioning it? Because it's very important in our scenarios. As you introduce people in your own community who are infected coming from airport and so on. So we have this capacity in our model to introduce people in the pool of susceptible and exposed as well by removing people from infected and infectious in order to control the exponential growth in our model. We do 1,000 rows for mortality, 1,000 rows for everything, and we do this distribution in our model, adjusting for everything else. We're forecasting the covariate into the future, all the mobility, everything. Then we add them in the model to forecast the mortality and so on. We're predicting a beta and moving from a beta to R, which people call effective R, not R not. It's R is changing throughout the pandemic, and we're trying to model that. Let me briefly explain this because I want to show another slide about what's happening when we do this. And I'm deeply sorry about very hard to see it. So the first one, the shaded one, is mortality rate, and that's cumulative mortality rate, and axis are the time. The second one next to it is cases. So that's cumulative cases. And again, the y-axis is mortality rate, cumulative mortality rate. And the last one is cases that are admitted to hospital, so hospitalization rate. And again, hospitalization rate by date, cumulative hospitalization rate are what we are modeling here, and cumulative deaths is the y-axis. Now at the bottom, that's a daily reporting, so that's every day. So one is mortality reported on a daily basis, and you see the zigzag how it's going up and down. You see the increase in cases on a daily basis. Cases are increasing. This is in Alabama. With time, we have more cases. It looks bad, but actually Alabama is doing more testing, so you have more cases because you're doing more testing. Look at the admission. It goes up, it comes down. And the model is the red line, is trying the random knot combinations line is trying to figure out what's happening here. So it's going up, it's coming down. And now because adjusting for the new cases, which you hear in the United States, we have more cases, and it's not due only to testing. The model is saying in Alabama is going to go up right now because we're finding more cases even when we adjust for testing. We haven't seen it in hospitalization yet. And in the US, there is a strange phenomenon right now where we're seeing more infection. Admissions are not matching the rise in infection. And we don't see mortality yet because it's the younger generation that's been infected, more likely to be asymptomatic, more likely not to need a hospital. We do this, we have a very powerful computational infrastructure, so we can do 250,000 SER model at one time. So we could run these find a confidence interval, and we can make sure that we have uncertainty around every estimate we do. The beta right now that we are modeling in our EIIR model takes into account, and the variable that we use is mobility from what I showed you, and I'll give you another example. That's the percent reduction from the baseline before COVID-19 started. We have data historically. Population density more than 1,000 per kilometer squared, the proportion of the population. Pneumonia seasonality, because we're finding a strong correlation between pneumonia seasonality and COVID-19. It's a seasonal virus, but it's not flu. Otherwise, in May in the US, you wouldn't see flu. We're seeing, coming down in terms of mortality, but we expect it to go up in the US at the end of August, early September. Same in every country in the world, matching the pneumonia seasonality. Testing reported to us how many tests are done every day. Mask use, which comes also from our surveys, and I'll show you data. Particulate matter 2.5, an environmental component capturing pollution, lower respiratory infection, mortality rate, smoking prevalence. Altitude, we are finding that the higher altitude, because similar to pneumonia and effect of seasonality, it makes a big difference. We're adding this. We're testing right now humidity to add it in our model at the request of some of our colleagues, and of course the mandates. Current projections right now is the current prediction, what we say is our reference model. We're assuming that if COVID-19 mortality daily death rate reach 8 per million, and this is a 95% when the countries impose restriction in the past. So we're looking at the data in the past and what country did do. And at 8 per million, we felt that's the point we can use. So we're assuming anywhere in the world it reaches 8 per million, restrictions will come back and mandates will come back, and we model as take the experience in the past and let our priors assume this is what is going to happen after we reach 8 per million closures and what happened after the closure. And then one of the scenarios is keep business as usual. We're opening for business, allow it to keep going. We don't believe this will happen, but we're providing that model. Widespread mask use, 95% using any mask. And here the mask use, we have done a meta-analysis here at IHME. And it's in press, and we're taking the lowest effect from any study we have, which is 34% reduction in transmission, and we're applying it in our widespread mask use. So we're underestimating the mask use, and that's from a class mask. So any mask you make at home, as long as you cover your mouth and nose. And we have 2 weeks on, 2 weeks off scenario, 2 weeks on, 6 weeks off scenario. 6 weeks off means you open the business for 6 weeks, you close for 2 weeks. When the death rate reaches 5 per million per day. So briefly, let me show you what we have from the United States. This is the June 23rd, our data looking at the mask wearing. And today, one of the problems that I had yesterday is Palestine is not showing here. So please don't send me an email. I screamed bloody murder yesterday because somebody made a mistake, didn't put Palestine here, but the borders show Palestine, of course. Percent who say they always wear a mask when leaving home. You could see it, it's very high in Saudi Arabia, in United Arab Emirates, over 80%. Let me be careful here when I say it's very high in Saudi Arabia. This comes from Google, which comes from smartphones or smart devices. So definitely, when you look at Egypt and you say in Egypt it's 40 to 50%, for example, or even in Saudi Arabia, that's an overestimate of the real use of masks, because these are the rich people who are more likely, or the affluent people who have access to such devices and willing to take a survey by Google and Facebook to answer these questions. If you look at it globally, the run is from June 23rd. This is yesterday's run. June 19, you could see in many parts of the United States we don't do a good job, but what you look here is the big impact of the seasonality when we come to the discussion is you see high use in the Southern Hemisphere. Take Australia and New Zealand. New Zealand did a good job controlling COVID-19. But look at Argentina, Chile, high use, strong mandate, COVID-19 is going up because they are in their uptake of pneumonia seasonality. In the United States, we have a long way to go in terms of mask wearing. COVID-19, this is the US, 1 year, 5 years in the past, and you could see here how COVID-19 goes up, comes down. We were lucky in many ways in the US and in the Arab world that COVID-19 hit at the time when the seasonality was going to our advantage. It's coming down, and now it's going to come back again in August, September in many places in the region. So if you keep that in mind, we were hit with COVID-19. There's nothing good about COVID-19, but a good time in terms of its seasonality. It was coming down and going up. Whereas right now, what you see, the explosion in Brazil, Argentina, and Chile, with even strict mandate in both Argentina and Chile, and people are wearing masks and adhering to social distancing, we see cases rising as well with all the measures in place. Testing per 100,000 population, and I'm going to talk about the limitation to the data. We see more testing in Qatar, United Arab Emirates, in Saudi Arabia. Not surprising in the Gulf and Oman, where the testing is much higher per 100,000 population than in many other places in the world. And I have 4 minutes. COVID testing and globally, let's skip that. A percent reduction in mobility, it's coming down in many places, but not as much as we would like, 25, 30% globally. We're not doing very well in the United States and actually in many places in our region as well. The important part is effective R. We see effective R is more than 1 in many of our countries, so it's going up. And that's effective R on June 9. So in many places in the US, it was coming down, but you could see Texas, Florida from our data, and Arizona, that's coming up. That's a big. Briefly on our model that you will see today, Egypt, we're projecting by November 1st, 55,000 deaths. We will think that Egypt will impose mandates sometimes around October 1st if they will reach 8 per million in our estimates. The green line is the most important line in what I'm showing you here. If people wear masks in Egypt, there'll be a delay of the mandate. You see, November 1st, there's no mandate still in Egypt. If 95% of people of Egypt wear a mask, and a huge reduction in deaths, just wearing masks, again, at 34%. Mobility in Egypt, if you trace it, just before Ramadan, you see the bump came down around the Eid. After the Eid, a little bit came down, then it's going up again. I'm not going to show other countries because of the time. Let me move in briefly what I want to discuss. The data will be available. Our limitation, we have under testing, under reporting in many countries about mortality, and we don't know in many countries the new bed capacity because they have done their own surge and they moved canceled the elective surgeries, for example. We don't know how the testing is done. We don't know if it is a random sample. We don't know, are they testing at hospitals or are they testing random people who are walking in the street? And we're not able to compare from one day to day the percent positive because we don't know how the sample is done. And we don't have hospitalization data for many places. Briefly, in Pakistan, if you look at this in Pakistan, this is the daily cases, the one in the middle on the left. Cases are coming down, testing is coming down, and new cases on the left, new cases are coming down, the blue color only. So when you look at Pakistan, they're not reporting mortality. They're not testing anymore. Our model, the bottom one, is saying the first run, we had 54,000 predictions for Pakistan until the October 1st. Now we have 22,000 deaths until November 1st. That's dysfunction. You stop reporting cases, you stop reporting mortality. Our model is going to say it peaked, it's coming down. You start talking to people in Pakistan and they'll try to explain to you, no, that's really what's happening, and I'll come back to it. Excess mortality is a big problem. This is Spain on one side, Ecuador on another side. COVID-19 total deaths increase in deaths. You could see every country in the world, even those who have a good vital registration system, even in the US, we have an underestimation of total mortality. And if we go to excess mortality, there is much more deaths from COVID-19 than what we are reporting, much more in Ecuador and of course in our part. And the EMR, very brief, a few slides, sorry, excuse me, so came on top of poor health conditions. Came on top of health disparities in our region, came on a part of the world that has never, sorry, again, I'm being frank and scientific here, didn't invest in public health at all. We focus on healthcare, unfortunately, open hospitals, and even when we focus on care, we don't do much on primary health care. We do more on high-end hospitals. And of course, for the first time in the Arab world, and let's be honest about ourselves and our region, it shows the impact of social and economic equity. We're scientists here. This is a scientific debate. It shows, for example, in countries like in the Gulf, where the people who are working in the Gulf, foreign labor, if you don't take care of their health the way you take care of your own population, they're essential workers. They're going to get infected. They're going to pass it to you in your own community. Same in the US. African Americans are minority in the US. We're struggling in our part, balancing the economy and opening the country, and then we are monitoring what will happen on behaviors when you ease the mandate. In the US, we ease the mandate in certain places at the right time, in other states prematurely, and now it's increasing almost everywhere. We haven't looked at long-term consequences of closure. So if you take a country like Pakistan, shutting down, what's the impact of malnutrition, immunization, where you need Egypt, exactly the same way. What's the impact long-term? And then you're, as a decision maker, you're gonna lose a lot if you close, and you're gonna lose a lot if you don't close. And that balance is very important. Testing. You say test, the testing in the US is very expensive in every country in the world, $10 to $20, my estimate, rough estimates for Lebanon. To come to a country in Pakistan and say test 10,000 a day, which they were testing about 6,000 a day, that's $200,000 a day that Pakistan could invest, or Egypt could invest somewhere else. What happened in the Middle East, which is very important, all countries in the world closed in March. This is the number of mandates that were introduced, 6 mandates that I showed you. This is the number by region, by country. All of them came in March. So what happened is in many countries in our region, when they shut down, there was less seeding. The virus wasn't circulating in our community, gave us all a full sense of security. We're doing very well, to the point that some people in our region started saying that we are immune and we have certain genes that will not allow us. If you open prematurely, and even if you open when it is right, we have seen that in many places. The virus being highly contagious and we're all susceptible, it's going to go back to exponential unless people are very careful about it. A second wave, there is no way around it. It's going to come, especially with the seasonality of COVID-19. Our data allows you to plan for the hospital. I didn't show you this because of the due time. What do we need to monitor EMR in our region, and COVID-19 in our region? Of course, we don't have good mortality data. We really need to understand the random sample that you are doing for infection and antibodies. Consider doing a panel. So don't do a large sample. Keep some of them in the second round of sampling, so you increase your power of detection and the confidence interval between one. Report hospital admission for COVID-19, because with testing and admission, we can tell how many are tested who are asymptomatic. We can roughly estimate that. And tell me the testing breakdown. When you say I'm testing, how many did you test in part of tracing and how many you are tracing? And maybe in our part of the world, we can do it for a country like Egypt or Pakistan. Consider doing it in 3 small areas in your country, low, medium, and high risk, in order for us to understand and you to understand what's happening here. Public health message is what we have right now to control COVID-19. So what we have, inform the public to wear a mask, protocol for safe opening every business, CDC has them, copy them from CDC. Consider this pulse approach, yes and no. Selective lockdown doesn't work in our region. And shielding, which is basically let the younger people go and work, doesn't work in our region because we live with our parents. And you really build, there is no trust in our governments. Let's be honest about it. Build the trust and prepare for a second lockdown. You need to prepare in our region for a second lockdown. You need to support poor families to stay at home. So in Yemen, if you tell people stay at home, they tell you, I'm happy to do it, but who's going to feed me? It's cheaper to give them $35 a basket for a month for food to stay at home than testing 5 people at $20 per test before and after. So it's cheaper to pay them to stay at home than testing them when you have an outbreak. Stay home, cover your mouth. These are the public health phases in opening. Make sure the priority is for medical system, build the trust for people to come back to your institutions. Food security, transportation, and of course, opening a business has to be like in college, 101 before 201. So what's prerequisite? I'm done here. Vaccine, seems that we may need 2 doses for the vaccine. From what I'm seeing right now, we need 8 billion. Who's going to get it? Priority the medical staff. We need 200 million doses for at least to protect our hospitals, our primary health care unit. What we have learned, we need ensemble models. Updates are important. Media is big power in our data. Poor data everywhere. Opening the university, somebody asked me to talk about it. I doubted that it will happen. Honestly, we are seeing outbreaks here at UW. We monitor our model, how it compares to the others. And we had an outbreak in one of our Greek houses here. And now we have 50 of our students who are staying there who have an outbreak before we open. So thank you, everybody.
Thank you, Dr. Mu'dad, for your presentation. And now I'm going to, and for sharing these projections for our region and insights. Now I would like, please, to give first the floor to Dr. Haji to comment on the projections. I will start by introducing Dr. Haji. Dr. Haji is currently holding the position of the Director of Program Management at the WHO EMRO. Prior to that position, she was Director of the Department of Communicable Diseases Prevention and Control, where she played a major role in supporting emergency response in the region and in accelerating the agenda for prevention and control of several infectious diseases. Prior to joining WHO EMRO in 2016, Dr. Haji was working with the U.S. Centers for Disease Prevention and Control for 23 years, where she held many senior positions with complex management responsibilities, and she has worked extensively in the Middle East. Dr. Haji is highly published and holds visiting professor positions in medicine and public health at Emory, Johns Hopkins universities, and we're very happy also to have her at AUB. So Dr. Haji, without further ado, the floor is yours. You have up to 10 minutes, please, to comment. Thank you.
Yes, thank you very much, Ghina. Thank you, Aline and Iman, for inviting me. And good evening, Masal Khair, everyone. Good morning, Ali. You're too early, and it's great to listen to your presentation again. I mean, this is a very hard act to follow and to actually comment on in 10 minutes, although I do have the advantage of having seen, and I appreciate really the IHME's effort to keep the regional office on board and updated with their model and their projection, and also with their willingness to help with other areas that need support. So, you know, I thought it is best to maybe give you a quick overview. I mean, I have few comments, not per se on the model, you know, itself. I'm not, as a disclaimer, I guess I'm not a modeler. I am an epidemiologist, infectious disease physician and epidemiologist, and I spend a lot of time critiquing models, so, but from an epidemiologic perspective. And what I would like to do is to kind of put this model in the context of the region, what is happening, how these models have helped us overall in the region, and in terms of managing the pandemic and controlling the response. So as Ali mentioned, and as you mentioned early on also, Ghina, I mean, we have had a very unique situation in the region for actually all the factors that you have mentioned, not a single factor. I mean, other than Iran, where you know, there was an explosive outbreak, and they are now going through another explosive second wave. We've had a very slow pandemic progression in the region. Maybe we were lucky, but you know, what we have found in Iran, we had a mission visiting there just on the side, is that their first case was reported at least a month, or was identified at least a month before they found it. They did not think at the time it was a positive case. So it had been circulating for at least a month before the pandemic was detected, which we were able to avoid in the rest of the region because of the early application of some of the restrictions measures. But you know, I mean, I always tend to be a bit on the optimistic side, and I do think we have a few countries in the region that are currently doing very well, where we consider that the situation has been controlled very well from the beginning, and where up till now they still don't have evidence of community-wide transmission. Countries, mostly, you know, the mid to upper income countries. They include Morocco, Lebanon, Jordan, and Tunisia, where these measures and the closure of ports of entry were taken very, very seriously. Maybe just a couple of quick words about the region in terms of why we as a regional office, we were very, very worried early on, because we are a very fragile region. More than half, 12 out of our 22 countries. And you know, we cover, in addition to most of the Arab world, we cover also Iran, Afghanistan, and Pakistan. So 12 out of 22 countries are in some form of emergency or humanitarian. The largest proportion of refugees actually of all the WHO regions. So more than half of the refugees in the world are actually in this region. We have many migrant workers, as you heard, many vulnerable populations. So we were very concerned about, I mean, very, very simple things like, what do you do with these people when they get infected? Where do you put them? I mean, you know, we didn't even have answers to that. And then, of course, the quite significant disparities in terms of socioeconomic situations. But, you know, nonetheless, even some of these vulnerable populations initially, like refugees and migrants, we were watching our camps very closely and cases among refugees, and they had very, very few cases. Up till now, we actually continue to see very few cases among refugees per se and IDPs, which probably was, I mean, we don't know exactly, yes, what, why, but probably related to you know, slow introduction, since there wasn't a lot of interaction with imported cases early on. So why, I mean, why this is important, and why have we really developed a lot of interest ourselves in modeling? I have never seen policymakers so interested in models for like my over 25 years career in infectious disease epidemiology. So I think, you know, just that mere fact of being interested in modeling and trying, I mean, we spent a lot of time with our communication people trying to explain in simple terms to policymakers what models are, what are the limitations of models, what determines the quality of a model. And that by itself was really helpful. You know, we had, of course, to explain especially the limitations, because we all know, I mean, I won't say the same, but we all know, you know, the quality of the models and their outcomes or outputs depend on the data you put into the models. And that allowed us to emphasize the importance of data quality at the regional level in countries, the importance of epidemiologic capacity, of good surveillance systems, information systems. And, you know, I know that moving on, we're still in the acute, relatively stage of the pandemic, but we know that support to public health system strengthening and overall health system strengthening will be very different after the pandemic, and we're being very opportunistic and taking advantage of that. But, you know, highlighting the importance of data was very critical. So, you know, for us, compared to, you know, to the IHME model, what we have been doing, and this is actually the first time we developed a small modeling unit in the regional office. They started working with the Oxford model that kind of progressed over time to become the COMO model, because there's a consortium, as you know, of many countries and many institutions now. And this model is also an SAIR model, but it's more of a you know, mathematical model. It has its own limitations. But I think one of the advantages, I guess, of the regional office is we have access to country data. And one of the advantages of countries requesting us to work with them on modeling, that they were willing to actually share a bit more data. I mean, the data quality varied between country to the other. The testing strategies are, there's a huge differences in what each country is adopting as a testing strategy. And that by itself has a lot of implications, even the reporting of deaths, as Ali mentioned. Not all COVID deaths are reported as COVID-related, for example. I mean, we may want to consider more looking at all deaths in the region because some of the COVID deaths are reported as the comorbidity being the primary cause of death. That's what we learned from some countries, and that also, puts sometimes another limitation on the model we are developing. So as I mentioned, the modeling, the interest in policymakers to actually have their data modeled so that they can make decisions about how many ICU beds do they need, how many ventilators, whether they should lift the restrictions or not, was very useful. But we also wanted to highlight to them that the models are only one part of the decision-making process, that countries should not be relying just on models, because actually this was a bit scary, and I'm sure for Ali it's scary too, when they put so much burden on the modelers to come up with the data to make all their public health decisions. Countries should take into account many other characteristics, including, of course, their own health system characteristics, whether they're able to handle, the epidemic or not. I mean, we always tell them to do risk assessment, but I think we need to help countries do better data-driven risk assessment. They take into account, the economic context, the social context. There are many community parameters that we are asking them to take into account, in particular, feasibility of certain measures, social acceptance. And as we move on, we're kind of now, I guess, getting into the second stage of the pandemic, and countries are opening up, whether we like it or not. I think some of these factors become more important in helping them, and actually for us, in helping them using these models to better manage the pandemic. Maybe one thing I wanted to mention, and I don't know, Ali may comment on that in the discussion, is that one of the limitations of the COMO model is it's more of a homogeneic model. So it looks at how disease mixes in the country at the national level. And we have some huge countries in the region, like Pakistan, where just one province, Sindh or Punjab, may be bigger than many other countries or group of countries in the region. So how to do modeling at the sub-national level, I think, becomes important. One thing I'm not sure we can go back to the full lockdown, Ali, because countries are really tired of the full lockdown and the populations are tired. So what we are recommending right now is to do the cluster management. And as countries open up, we are recommending that they monitor very closely, which requires a good surveillance system, early detection, etc. They monitor very early on the cases and any clusters, and then do lockdown at sub-national level, sub-regional. This worked very well in Lebanon. I think you all have heard about what happened, for example, in Psharri, in another, what was the other location? They were mentioning it to me as really they did really well in terms of it was just a locality where the local municipality really quickly put control measures. And I think this is going to be the way to go. Hopefully, if the number becomes out of control, there may be need for a full lockdown. So, just also wanted to mention how have countries used these models in addition to the well-known things like predicting hospital beds, etc. Countries have been asking us, for example, for certain situations like Ramadan or some of the other religious gatherings in our region. We have many this is one of the other defining characteristics of the region, is the many religious sites, which was the source of the pandemic in Iran and in some other countries like Iraq. And for Ramadan, for example, we applied the model specifically to look at the implications of, what measures to put during Ramadan and Eid. And some countries like Jordan, Afghanistan, were specifically relying on these models to guide their decision. So maybe, I think in the interest of time, moving on, I still think, the model that IHME presented is really helpful in terms of the key messages, practical messages they're coming up with, the importance of mask. Mask wearing, I think it is really a very good and very simple message that can be sent out to the community, although taking into account, like, can we really reach 95% mask wearing? It's almost impossible, but many of these interventions, we need to put on it some feasibility and practicality concern. Again, as I mentioned last, is the importance of risk communications, community engagement, because this is moving on. There is no country in the world, I think, that's going to be able to enforce any of these measures completely. And the importance of this shared responsibility with the community becomes really critical. And last, again, I would like to thank AUB, IHME and others for the chance also to present, but also to collaborate. I mean, I look to further collaboration. We are working with many other institutions in the region. As I said, we see it as an opportunity to build capacity in our countries, not just for modeling, but for epidemiology and for surveillance, and to increase the trust in public health systems, and the importance of good preparedness and sticking to international health regulations in terms of further management this pandemic and others. So thank you, and over to you.
Thank you very much, Dr. Haji, for these important insights based on your really experience working practically with at country level, and knowing all the limitations and the capacities of each country. Now, not to further, for the sake of time, I will move immediately to our second discussant, Dr. Abu Raddad, and after that we will open the floor for the discussion. And maybe also Dr. Muqdad will get the chance to address some of the questions that you have raised for him. So I will introduce now Dr. Abu Raddad. Okay, so Dr. Abu Raddad is a professor of healthcare policy and research at the Weill Cornell Medicine in Qatar, Cornell University. Previously, he had academic and research positions at the Fred Hutchinson Cancer Research Center, University of Washington in Seattle, at Imperial College London and Osaka University. His research interests are multidisciplinary, with emphasis on studying the epidemiology of infectious diseases using analytical and computational approaches, mainly mathematical modeling, in addition to conventional epidemiologic study design. He has led several high-impact studies, including in Science, Lancet, PNAS, and others, and his research work has been key in the formulation of public health policy at the regional and international levels. I know that Dr. Abu Raddad is currently leading several research projects on SARS-CoV-2. He and his team are actually modeling the epidemic in Qatar and other countries in the region. And Dr. Laith has been advising the Ministry of Public Health in Qatar in the response. And so this puts him in a very good position also to provide some more maybe technical also comments on the epidemic based on his experience modeling it in the region. Dr. Abu Raddad, the floor is yours.
Thank you very much, Ghina and Iman and Aline for the invitation. So it's great to see this actually modeling projections coming from IHME. I believe modeling has really very important role to inform policies in our region, and in terms of resource planning, projections for and forecast for the epidemic over the coming months and even more. So these have a lot to play in the region, and which is stressed also by Rana just now, and I hope to see more of these happening. So today I just want really to complement what has been presented by Ali and Rana by trying to answer a few questions based on modeling as well as empirical data, which relates closely to what has been presented. So first, is probably many would ask, at what stage is the epidemic currently here? Now we have growing amount of data from different countries. For some countries, such as the ones I am showing here, Egypt, Saudi Arabia, Iraq, and Pakistan, we see what appears to be an exponential growth in the number of cases, which are also confirmed by the modeling. And it looks like the reproduction number is significantly above 1, even though it's not very high. It still is above 1, so we have an epidemic expansion. The epidemics appear to be somewhat in the early side as well overall. It looks like for the majority of countries, the attack rate, that is the number of people who have been infected so far, is below 10%, which means we are still way before, before herd immunity is reached. So there is a lot of epidemic potential for the for COVID-19, which will continue for a while. And of course, it will get even worse with the easing of restrictions if it goes too quickly and not in the best way possible. Now, these are some group of countries, but as Rana just actually indicated, we do have really successful interventions in a few countries like Lebanon, Jordan, Tunisia, and Morocco. And these have definitely slowed down the transmission. In fact, it looks like the reproduction number is substantially actually below 1, or they managed to reduce it through the interventions to below 1, which is really great. But it means also very little herd immunity is being built up in these countries. So they will have, in a sense, to continue with this ping pong, with the virus for a while, of easing, probably later on imposing restrictions as the epidemic expand and so on. We do still have also few countries where the data seems to be very limited, in large part because testing seems to be a bit precarious and not very consistent. So another question is, why does this region seem to be less affected? Now, Ghana, in fact, very nicely in her introduction alluded to several of these reasons, and indeed there are several reasons seems to be playing. But here is actually one of those reasons, which is the fraction of infections that are asymptomatic. So this result here is based on a community survey we have done in Qatar. So when we did this cross-sectional survey, it turned out almost 60% of those who were actually infected, they were PCR positive, but they indicated that they did not have any symptoms in the last 2 weeks. So this indicates that there are a lot of infections that are asymptomatic and not being captured by testing in our region. And this is really confirmed more so in Qatar, because Qatar, we have one of the highest testing rates in the world. And a lot of what we find, the infections that we diagnose, are actually asymptomatic. So this is one of the reasons. Probably this possibly is related also to age. We have quite young populations in our region where the infection affects them much less than the elderly population. In fact, this is one of the really main reasons why this region seems to be less affected, at least up to now, by this pandemic, because of this young age. So here is another study also from Qatar, where we tried to assess the severity of the disease for the different age groups. And in summary, really the result, this is true for severe infection, critical infection, and also for COVID deaths. It's very, very clear. Age is by far the strongest predictor of severe disease and of mortality. The infection in the younger age groups is really very, very mild. It's quite rare for the infection to be severe or critical, or for a person to die from the infection. However, it increases very rapidly once people cross 50 years of age. Now, there aren't really a lot of people older than 50 years in our region. I mean, in Qatar here, for example, it's actually less than 10%. So this contributed to the severity of the disease, of the epidemic, being less in our region compared to other regions, and also contributed, I think, to the epidemic being not visible as it is for the other regions, because it's simply there aren't as much disease as it is for the other regions. This picture is also confirmed now in some also preliminary results of modeling, trying to estimate the infection fatality ratio in IHME countries. and the severity ratio. And here is actually the estimate for the fatality ratio. It looks like the median is around 2 in 1,000. So out of every 1,000 infections, there will be only 2 deaths. And quite possibly this is an overestimation. I think this could be substantially even lower than this. So this, I'm not saying this really to underestimate the potential of this epidemic. This epidemic has a lot of potential to cause a lot of severe disease and mortality, and even for many healthcare systems to collapse. But definitely less so than in other regions. So it's not the same infection fatality ratio that we see in other regions. Similarly, for the severity ratio, it's actually just above 1% estimated, or 1 to 2%, which could be also overestimating potentially. But we are talking about only 1 in 100 cases that would need actually hospitalization. So these are good really factors that are helping us in our region. But of course, we need to prepare for the epidemic expansion if it gets bigger and bigger, because healthcare system could be totally overwhelmed because of the number of infections. So even though the ratios are low, the number of infections could be very, very hard. Now, one of the biggest questions going on, which in fact Ghana nicely started talking about, and Ali also presented, and Rana, is about easing of restrictions. I think Rana stressed really how it is very hard now to really go back in time and impose more and more restrictions. People are really fatigued by these restrictions. Governments are also very worried about the economies in their countries. So it's likely there will be more and more easing of restrictions, which already started. But here are some modeling results that show what could happen. So if we ease the restrictions too early before we hit the epidemic peak, this will create actually potential for further fueling of the epidemic, which will result in even a bigger peak than we would have otherwise with keeping social distancing restrictions. So this is really not the best scenario. This is not really what we want countries to do, to ease restrictions too early. And we just have seen what happened in the US, in fact, to this extent. But it's perfectly understandable. There are many other factors for decision makers to consider before these decisions. If, however, countries will ease restrictions after the epidemic peak, the epidemic will become much more manageable. So it will lead to more prolonged cycle, but at least it's more managed cycle, because the incidence will not be as high as if we ease restrictions too early. So these are just few results just I want to share with you, just to complement what have been discussed and earlier by Ali and Rana. So I think this region has definitely protective factors that had helped us, but these are not enough, of course, to confront a very serious pandemic that's undergoing everywhere. Thank you very much, Ghana, and pass it to you.
Thank you very much, Dr. Laith, and also for sticking to the time limit so that we can allow more time for participants to send their questions. So we would like to, although it's already 6:05, we would like to allow around 20 or 25 minutes for Q&A for the audience. So I hope that the audience will be able to stick with us with a little bit longer. I already have one question in the chat box, but before that, I will just give the floor for Dr. Maqdad for 1 minute, if you would like to answer briefly one of the questions that Dr. Haji has asked about how can you account in these modeling for subnational heterogeneity in the epidemic.
So thank you. Briefly, I'm going to comment on some that Laith and Rana, Dr. Laith and Dr. Rana said. So younger age in our region was spared. And you have to be very careful what you're saying here. Our region was spared because we locked down before there was seeding not because we are immune or because we have a younger population. I mean, that's a mistake. We have to be very careful. Look at what happened in Iran and Jordan. Iran locked down when there was so many infection going on. It kept going up. Jordan locked down with the little infection, so it didn't spread. Younger generation in our region works against us, not for us. So we have to be very careful from the public health. Yes, they're less likely to get the disease, to be showing the symptoms. But who in our region as a young live by themselves? I mean, we live with our older population, so we have to be very careful on that. We don't have a fatality rate, sorry, Lace, in our region. We don't have a denominator. We don't know how many people are infected. So we have to be, again, COVID-19 is going to behave in our region exactly like it behaves in every other country in the world. Africa has younger population as well and have similar culture. So we have more disadvantaged people, we have more malnutrition, we have wars, we have refugees. So our region is set for an exponential growth if we are not very careful. So Rana, in terms of the lockdown, IHME has subnational data. We have subnational for Pakistan. We have even at the lower level in many countries. We do here state and counties right now. So we have the data at the local level. We could do this at the local level as well. In terms of a lockdown, local lockdown, and not a countrywide lockdown. Sounds very interesting that I can lock down Sharri, but you and I know very well in Pakistan when they said they're going to lock down, people moved from one area to another. In the US, when a state locked down New York, rich people in New York came with their infection to other places where they have a house and then stayed in the village or whatever. So we have to be very careful. This localized lockdown in our part of the world, does it work realistically? And we have to be very careful. The other thing that Rana said about the models, that the models are not good. Everything we do in life right now is based on model, or our economy is based on model. The debate in our region shouldn't be about the model, it should be about how bad your data is. If you have good data, the model will do very well. It's the bad data. And that's our time in our region. Instead of focusing on the models, if they make a mistake or not, to focus on the crappy data that our region is producing, because the models do exactly very well in countries where there is good data. So, and we do models for everything from the way we buy books, we watch movie, and our economy. So I want to shout out here for quality data in our region and use this event to improve the data as we have the attention of everybody in our country. We're so vulnerable in our region. This is a false sense of security that we were spared. And I'm not trying to be an alarmist here, but that's a infectious disease that's going to spread widely. Over.
Yes, thank you, Dr. Ma'dad. I think there is a bit of maybe misunderstanding about what Dr. Abu Raddad has meant with the rule of age. So I wonder if Dr. Abu Raddad would like to comment on this point.
Sorry, before I meant age work against us in one thing, that younger people live with older generation.
Yes,
so that's what I meant.
Intergeneration mixing. I
Exactly.
see the point. Yes, but I think that Dr. Abu Raddad mentioned something else in terms of the severity maybe of the disease. Dr. Laith, maybe you can clarify your point.
Yes.
We cannot hear you, Dr. Abu Raddad.
Severity doesn't matter. I mean, let's be very careful. It's once you are infected, whether severe or not, as a young adult, you're spreading the virus to your older generation.
You're infectious, I understand.
Yeah, there is no need to focus on like younger adults are going to live longer because they're protected. Yeah, so
I think this is not the point. Yes, I think this is not the point. So I will leave the floor for Dr. Abu Raddad to express himself.
Yeah, thank you, Ghina. Thank you, Ali. Yeah, can you hear me?
Yes, perfectly fine. Thank you.
Thank you. Yeah, no, definitely intergenerational mixing is a very important factor. In fact, we have seen it in Italy, where apparently one of the reasons for the higher mortality was the intergenerational mixing. But yeah, this is not really the point I'm talking about. We're talking about a region where the average age is actually quite small. If we take, let's say, Italy, where the average age is close to 50 years, so clearly there are a lot of people above 50, and the disease is really severe among older people. The average age at death with COVID in Italy was 79 years old. So clearly a lot of people who died were actually very, very old. We have very small of this population in our region. The average age in our region is actually quite low. It varies from one country to another, but it's actually generally really quite young. So if out of every 1,000 people who will be infected, definitely severe disease will be less than it is in a country like Italy or in the US. And the same is true in about mortality. But again, I'm not trying to underestimate the epidemic. I'm just saying this is actually something good for our region, because it will reduce, we will not, I mean, healthcare demand will not be as high as in a country where there are a lot of elderly populations. This is really all what I'm saying. It's an opportunity for our region because we can capitalize in this. You know, it will help us prepare easier, you know, for what is coming. Yeah, thank you.
Yes, thank you, Dr. Abu Radat. I will take one question from the audience, from Hani Tamsah, who said that how can healthcare workers prepare practically for this resurgence or for the second wave? So
yeah, maybe I can.
Dr. Hajji.
Yeah.
Yes.
Sure. No, this is a very good question. But again, maybe to clarify a couple of issues, I think we never really said that the region was spared. What we said is that the first 6 months of the pandemic were relatively slow in our region, which is a fact based on the data we have, even though we probably think the data is not complete. And then, but we are very much threatening or worried now and concerned about the second wave, which we think it will be much worse, and we are starting to see it in many of the countries that opened up really without a very strict enforcement of certain measures of social distancing. And then the other issue regarding the models, of course, you know, we all know limitations of models, you know, but we are on the contrary, we're actually telling countries that models are a great tool for you to help you plan, but we want you to also focus attention on data. We were getting requests for modeling back in March, where countries had really poor quality data. So again, we use the model or the incentive of the model to advocate for the importance of high-level quality data. Healthcare workers, to go back to the question, healthcare workers is a population that has been very disproportionately affected in our region. Unfortunately, something like over 10% in some countries in the region of the total number of cases is actually among healthcare workers, which is a pity. And it has been mainly for poor infection control. Again, this is another system weakness that was majorly uncovered by the pandemic, and because countries did not do enough to provide these healthcare workers with the adequate protection in terms of PPEs, the education and awareness and all of that. How can they do that? I mean, I think the healthcare workers themselves, can, of course, be very careful with the infection control, etc. But it's also a responsibility of the healthcare system, the governments, to ensure that they are adequately protected by providing them with the measures that are needed. They need to have adequate PPEs. I mean, it's like what happened in the US actually was worse. I mean, some healthcare workers did not even have access to masks or the in certain healthcare facilities, but that's a responsibility of the government, the international community in terms of, and the regional, of course. We take a big responsibility in supporting this particular area, and on their side, they need to make sure that they stick to the adequate implementation of infection control measures as well.
Thank you, Dr. Hajji. I have another comment by Dr. Baddoura, who mentions that we cannot avoid addressing the issue of the displaced population and refugee camps. So he does not ask a question, but maybe I would like to ask you also, Dr. Hajji, how do you view the response in terms of the specific needs of the refugee population in our region, and how is the WHO supporting maybe this issue?
Yes, thank you very much, Rina. I mean, this is getting into really more of the general epidemiologic issues that are relevant to the pandemic in our region. And maybe Ali also can comment on whether they looked, I think they did look in particular on the scenarios among refugees, because that's a very concerning one. What we have been doing so far is working very closely with some of the other UN agencies like UNHCR, the IOM, the Migrants International Organization for Migration, and others, as well as with the countries where the refugees and the IDPs and the migrants are located, to make sure that they have special attention to their needs. You know, for example, in many of the camps, like we worked with UNRWA, for example, to make sure that they have arrangements for, you know, if they have positive cases or, you know, how are they going to isolate them? We cannot expect people living in extremely crowded and poor living conditions or homes, small homes, to even devote one single room and one single bathroom for an infected person. In many of the camps, for example, they have been able to set certain facilities where suspected patients can be isolated, or confirmed patients who are mild can be suspected for treatment. We are basically advocating and working. Most of the countries have been treating the refugees as the same as the general population. In Lebanon, there was a memo actually by the Ministry of Health that basically the refugees, which in Lebanon is a special situation because the majority of them do not live in camps,
yes,
that they will be treated similarly to the general population in terms of admitting to Rafiq Hariri Hospital, for example, for case management, etc. But we are, I mean, it's a very tricky situation. This is one area where I mentioned we have been lucky because we have not so far had major outbreaks among refugees in the region. There's been very small clusters. Refugees, I'm talking, or internally displaced people, but the migrants workers is a different situation. But this is one of the vulnerable populations that needs a lot of special attention from governments and international organizations alike.
Yes, thank you. Dr. Muqdad, do you have any comment on the refugee in terms of modeling?
No, we adjust for density, so, and then we adjust for location in certain places where we have data, not in the Arab world, but in Pakistan and in India. We adjust even for migration for labor, so we can do that. Lucky in our region, the refugee camps, because of the lockdown and the low possibility of interaction with the outside world, except of donors coming in, we have been spared in our region. So.
Thank you. Thank you. There's a I have also a question, another question for, I have two questions. I will start with one question with, again, Dr. Haji. How do you navigate the economic implications of the lockdown and your guidance to countries? So, for example, would you advise to ease restrictions in countries like Egypt, even though they haven't reached the peak yet, but because of the economic situation?
Yes, no, it's been very tricky. You know, WHO published back in April, I think, late April, published guidelines for easing the restrictions. And these guidelines required countries to have a few criteria before they even consider lifting restrictions, including, you know, ensuring like a steady decline in their epidemiologic curve, at least consistently for 2 to 3 weeks, making sure they have capacity to deal with any resurgence, you know, making sure there's adequate community engagement. There was at least a minimum of 6 criteria that needed to be taken into account. Nonetheless, I mentioned earlier, countries are reaching a point, and since Egypt is our hosting country, we really feel it. I mean, in Egypt, for example, we were told that around 30 to 40 million people rely on daily wages. You cannot just keep people locked in forever, but we are also very careful in terms of making sure we don't put, you know, we're starting to hear slogans like lives versus livelihoods, or you know, economy versus health. I mean, this is not, we don't want one versus the other. I think the priority of any government should be to protect the health and the well-being of their population, while also ensuring that these people continue to, you know, to be able to make a living. So we are taking these into account. What we ask countries to do is to do a risk assessment. We're at a different stage of the pandemic right now. now. Countries like Lebanon, Egypt never really went into a full lockdown, but some countries did go into full lockdown, like Lebanon and Jordan, and now they are at a point where their strategy is changing. You know, they are willing to take a bit more risk. So what we tell them is you have to do your risk assessment. You have to decide how much risk are you willing to take, and ensure if you reopen that you have at least in place certain measurements, you know, like for example, improving testing at ports of entry as countries are opening up airports. I think very important to have at least the imported cases being controlled, and then enforcing isolation, which, I mean, I agree with Ali, it's very difficult to enforce actually anything at this point. But again, what we are recommending to mitigate as much as possible the impact of the severe economic consequences of the pandemic is to try to do some limited measures in certain localities, you know, whenever possible.
Ghana, can I say about the lockdown and what countries can do? The metric that we need to keep an eye on is hospital capacity. If a country wants to open up business, that's okay. Keep opening because there is a balance. Nobody is debating that. But once your capacity reaches 80% in your hospitals, you have to slow back. I mean, what are you going to do? Overwhelm your hospitals, put your physician in a position to decide who's going to live, who's going to die. There'll be riot in the street, and let's be very honest, there'll be riot in the street because of hospitals cannot admit patients. So that's the indicator we need to keep an eye on, and we need to educate our public to keep an eye on your hospitalization rate. If your hospital capacity is 80%, dial back. I want to say one thing very briefly. I live in Seattle. Dr. Lace lived here. Rana has been here. One of the most educated city in this country, one of the most rich city in this country, Boeing, Microsoft, I could name them all, Google, everybody is here. We had a severe lockdown. We opened down in phase 2 right now with all our education. My lab and one of my labs in my university does 10,000 tests a day. So look at our capacity in a city as small. We are younger than any population in the Arab world. Seattle, younger population than Lebanon, Jordan, and cases are increasing rapidly right now, and we're considering dialing back. So false sense of security.
Thank you. Dr. Maqdad. So I have 6 more minutes, but I would like to take a couple of more questions which have been sitting here in the chat. So one question is from Dr. Jocelyn de Jong, and maybe I will address it to Dr. Abu Raddad. So we have seen that male sex appear, male gender appear to be a risk factor for COVID-19. So Dr. de Jong is asking, there has been arguments that women biologically may be less at risk of contracting COVID-19, but at the same time, they may face high risk of exposure to the infection. So she's asking if the panelists can comment on gender differentials of COVID-19 in the region. I wonder, Dr. Abu Raddad, if you'd like to take this question, or if anyone else. Sure. Dr. Abu Raddad.
Yeah, thank you, Gana. Yeah, so in terms of global data, it seems that the risk of infection, getting infected, is not necessarily very different between males and females when we put all countries, all data together. But the risk of severe disease is actually higher among males compared to females. Now, drawing from data from our region, well, at least I know very well from Qatar. So the risk of infection among males is actually substantially higher than the risk of infection among females. But this is really largely due because who are the populations most affected by the epidemic? In the Gulf, the migrant workers who live in high density, housing and so on, this exposed them to more risk to get infected. So it's not really related to biological as opposed to just, risk
exposure.
Exposure, yes. Now, in terms
Yeah.
of severe disease, Now, in terms of severe disease, however, we were able to control for that. And we do actually see that men were 60% more likely to develop actually severe disease and critical disease. It happened actually for both of them. They were 60% in our setting. For death, we don't see statistically significant differences, but only because we have a very small number of deaths here. So we are unable, I think, to see the difference.
Thank you. Dr. Haji, did you have something to add?
Yeah. Yeah, just really a word of caution, you know, because these issues need to be really taken into account. Many other considerations need to be taken into account. I think, I mean, from the data I've seen in the region for both infection and severe disease, I wouldn't say that women are at lower risk, mainly because I think two things we need. I mean, a lot of things need to be controlled for, including exposures. Women are less likely to go out, you know, to the markets, etc., and mingle more in many of the countries. So I don't know, actually, Ali, I know you are collecting a lot of survey data, so I think it will be good to see mobility data, etc., to link it with that. But the other issue we need to control for also is the underlying conditions, in particular, you know, diabetes, cardiovascular disease, where we know that premenopausal women have lower prevalence of many of these, smoking, you know, and so many other factors, even for severe disease. I mean, the fact that you didn't see a major difference in death tells me that there's probably not even a major difference in even risk of severe disease once you control for all the zillion factors that we don't have very good data on. So just, I mean, again, you know, I think, Rina, that would be great, and I'll be happy to contribute to another maybe discussion on the full epidemiology of what we're seeing in the region, because I see a lot of interest. But I think really, I mean, the models, again, have helped us a lot because there's a lot of data in the models to understand some of these hypotheses that are being thrown out. We really, and maybe just Ali, really to reassure you that from interact, I mean, we're definitely not, we don't feel secure at all, even though we were very relieved early on that the outbreak didn't explode in many of the countries because we couldn't have dealt with it. But moving on now, to let you know that really we are getting on a daily basis, we are getting so many calls from concerned ministers all over the I mean, the region, but the Arab world. So there is a lot of concern. I mean, maybe they don't always show it. There's a lot of concern, and as a result, there is a hunger for the modeling data, for our advice, the expert advice, etc. I mean, maybe at the beginning there was this false sense, maybe some divine protection, but I think as the epidemic progressed and people started in Egypt now, there is not a single person who doesn't know someone who's infected, for example. And as a result, I mean, there is completely, you know, the population is scared, but there's not even adequate community awareness to you know, improve implementation of the restriction measures, such as wearing masks, etc.
Thank you, Dr. Rano. So very briefly, just to answer this question, which is here, this question is to Dr. Maqdad by Dr. Abla Sibai. She's asking that we're learning that the majority of deaths in the US and Canada, for example, are occurring in elderly homes, reaching up to, more than 60% in some districts. And this is part of the heterogeneity within countries. So do your models take into consideration this additional variable, and if it is stratified by locality, elderly home versus population based? Very briefly, Dr. Maqdad, if possible, please.
Yes, we do. We do our model, even like in King County, we do nursing home and without nursing home in our region. And yes, early on, mortality was higher in nursing home. Abla, you know very well, this is a harvesting effect. You know, in any event, people who are highly sick, they're more likely to die first. So there is a harvesting effect. Then it goes back to normality. We take that into account in the US because we have data about deaths outside the hospital. We don't see any variation by sex. These are it's a function of exposure and virus load. When you get the infection, determine how severe it gets early on. And the mortality, of course, is a function of pre-existing risk factors. Yes. I don't doubt in our mind that I'm not talking to you guys. Rana is a very dear friend. I worked with Rana at CDC. She was my neighbor, and she's still my neighbor in my mind. And Lace, I'm not talking about we're underestimating the virus or what the government are doing. I want the discussion to move to the public knowledge. Rana, that's what we're having a problem with, is the conception in the public. The leadership is different and the public is different. And our message has to address what the public are feeling. We're younger, we're immune, we didn't see it. We need to address those before the second wave, not the leadership. It's the communication to the public, building trust in the public, providing them the right information, basically telling them you're not immune, you're not young, you're not gonna get it, you are at risk, stay at home.
Thank you, Dr. Madad. Very quickly also, do your model take into consideration reinfection possibilities? Maybe Dr. Abu Raddad can also tell us about his model. Tfadal, please, very briefly.
From my side?
Yes, please.
Okay, yeah. So really, yes, we can, of course, easily include reinfection in the model. But at least in the most advanced model we have, which is for Qatar, we do not see really any evidence for substantial reinfections to actually accommodate in the model right now.
Thank you. And Dr. Madad, does this apply also to your model?
Yes, we have reinfection in our model, and yes, we are realizing right now from antibody studies that even if you get the virus, your antibodies is coming down, and we don't know how long they will last. So we include possibility of reinfection. As I said, we move people from those who are infected back to being susceptible and exposed.
Okay. Okay, thank you. And now the last question is about vaccines, and I will address it to Dr. Hajji in view of her also experience in the vaccine agenda. So the question is, how will the availability of vaccines and new medications for COVID change the disease pattern? And I would add to this, based on your experience, since the vaccine seems to be the only fundamental solution to the pandemic, how do you foresee first acceptability to a vaccine in the region if it comes available, but also the logistical consideration and deployment and access and in coverage? So I think we will end by this, if you don't mind.
Yeah,
maybe this needs
Rina.
a seminar on its own.
Exactly. I was going to say you asked at least 5 questions that will take each 10 minutes. I mean, you know, just maybe briefly, and hopefully we'll get to discuss later. This vaccines are going to be the solution, but unfortunately, we really don't have all the answers to your questions right now. There is at least 10 vaccines right now, more than 10 vaccines that have entered, you know, phase 2 and 3 clinical trials. We are very optimistic. You know, there are really huge efforts that are going on right now in the world to develop vaccines. Typically, it takes somewhere between 5 to 10 years to develop a vaccine, because we don't only look at effectiveness, we look at safety. And safety is really critical, and that's the issue of also community acceptance is important for people shy away sometimes from vaccines because they think they are harmful. So I mean, you know, there is a huge collaboration, global collaboration called ACT, Access to COVID Tools Accelerator, that WHO launched with Gavi, with various partners a few weeks ago. There are three major organizations that are responsible for the vaccines part, because they also take into account drugs, therapeutics, and diagnostics. And for the vaccine, we have CEPI, which is the Epidemic Preparedness Institution that is focusing on the research part, Gavi, because of the Global Alliance for Vaccine and Immunization, because of their experience with procurement, they're going to focus on the procurement and logistics issues, and WHO is focusing on all the policies and the allocation. So we are starting to work with countries right now, and with experts, because we already have, you know, the SAGE, which is the advisory group on immunization, and we have regional advisory groups in each region to come up with criteria for vaccine allocation. Because of course, even, I mean, we estimate in the best case scenarios that we may have a vaccine probably by mid to end of 2021. But even with that, you know, you need to ramp up the production, you know, so there's a lot of work going on now on creative financing to companies, identifying some of the large manufacturers that can actually quickly ramp up production, etc. But even with that, we're going to have very strict allocation initially to probably starting with high-risk populations, such as healthcare workers, some of the other, you know, vulnerable populations, knowing that vaccines typically don't work very well in elderly. But anyway, so we are working on coming up with all these criteria. We want to make sure that there will be equitable access. I mean, this is a huge concern for countries in low middle income, situations where they want to make sure that they won't be disadvantaged. And that will be the responsibility of the global community, Gavi and WHO, to ensure that these countries will not be left over. There won't be a monopoly of vaccines that are available and how this will be distributed. So right now, there's a lot of work going on. I mean, we don't have a lot of time, but we have about a year maybe to come up with all these criteria to ensure how we do that. But very importantly is we need to make sure these vaccines are safe. We have already started working with the communications group to develop communications messages about the, improving the acceptability of the vaccine. And by the way, I mean, and maybe this is a message, I've been saying this for 30 years, like, please make sure you get your flu vaccine this year. By the way, we are already noticing there's a huge demand for flu vaccine because people have realized that, at least they can protect themselves from one vaccine preventable illness that could have potential of increasing severity of acquiring another respiratory infection. But there's already a global shortage of flu vaccines because there's a rush of countries asking for that. So, we do have, I think we do have encouraging data about immunity from phase 2 trials, immunogenicity, I mean, but we don't really know how long this immunogenicity will last right now. And this requires a bit of a longer follow-up before these decisions can be made. So thank you, and more to come.
And Dr. Haji and Dr. Abu Raddad for your contribution and for your time and extra time that you gave us to address all the questions that we got from our participants. So I think that we will conclude right now. Thank you.
Yeah, thank you very much. Bye-bye.
Great. Thank you all. Bye-bye. Thanks.
Bye-bye. Thank you.